I'm going to reintroduce Dr. Sasakamoose, and she will now present on the topic of the Cultural Responsive Framework. Dr. Sasakamoose?
Hi. Thank you for inviting me to present here today. I'm a guest in Treaty 6. I've been living and working in Treaties 4 and 6 for the last 9 years, and so it's always an honor for me to be asked to present. I also take this role very seriously because I feel that when I'm asked to present, it's because I have something to offer, and so if anyone Indigenous is listening, I did smudge before I came here, and I did ask to be guided in this work because I think that even just some of the conversations I've had over the last few days, that I take for granted some of this knowledge, and I think that everyone has it, and I realize that sometimes I present information that no one's even had the opportunity to hear. So with that, we are in a sort of a Western setting, so I can't really model Indigenous ways of knowing, like opening with a prayer or having an elder here, but I could point out places where an Indigenous approach might be useful, and the first one would be in what we would call situating myself or locating myself. So typically when First Nations people meet each other, we identify where we are, where we locate ourselves. So what I want to do for you is give you a little bit of contextual background of why I'm here and how I might be useful today. I'm a member of a network that was recently started with Dr. Stuart Skinner and myself. It's called the Indigenous Wellness Research Community Network, and we also have the Wellness Wheel Medical Clinic. And in this, we decided to bring together Indigenous communities, Indigenous scholars, First Nations healthcare practitioners, non-First Nations healthcare practitioners. And what we try to do is we have an integrated collaboration. And we all do everything under ceremonial guidance. So we never go out and do an intervention in any way unless we have gotten sanctioning from the community, and we have done it in a local way in which the community appreciates and values. So what we try to do is strengthen the evidence between knowledge, practice, and policy in our program, so we can support the health goals of Indigenous people. We often do this through Indigenous community engagement. We meet together with communities, we sit down individually with communities, and we develop individual plans and processes. So I believe we are the only Indigenous-led network in the country, definitely in Saskatchewan. One of the things I'd like to do today is talk to you a little bit about what some of my goals are. And first of all, I'm not going to be able today to tell you everything you need to know about Indigenous people, but what I'd like to help you develop is cultural humility in order to build relationships with Indigenous people. One of the key learnings from today is that when working with Indigenous partners and all people, that cultural humility is a key component. As opposed to mastery of information about other groups, cultural humility is built on the concept of your own self-reflection and your self-critique and your skills critical to lifelong learning. There is no way to know everything about every culture, so we cannot become the experts. We need to shift that paradigm. The people are the experts in their own culture and ways of knowing. So the best focus I can recommend to you would be to build relationships. Cultural humility is a stance toward understanding culture. It requires a commitment to lifelong learning, continuous self-reflection, and one's own assumptions and practices. Comfort with not knowing and recognition of the power-privilege imbalance that exists between clients and healthcare professionals is key. A cultural humility approach is interactive. We approach another person with an openness to learn, and we ask questions rather than make assumptions as we strive to learn rather than inform. So one question I always say, and I teach in the counseling program at the University of Regina, and one of the things I teach my students as they're about to become counselors is a question, and this question is there anything I should know about you or your culture to support you better in this process? This opens up the door for meaningful conversation, and it works with anyone in any population. I'd like to just talk about why we need an Indigenous framework. First of all, how we frame the question is how we will look for the solution. And so often we know that, and if you look at any studies done on Indigenous people in Western-based peer-reviewed journal articles, it's almost all deficit-based, so we're always looking at the problems within Indigenous communities. So we really need to shift our paradigm from how we frame the challenge so that we look for the part of the solution. The culturally responsive framework does do this work for us. So by focusing our efforts on tracking progress towards our most important values and aspirations, we will become the communities that are working towards health and wellness rather than just documenting deficits. The culture responsive framework focuses on a paradigm shift. So the current Western paradigm of health delivery has failed Indigenous people. I think that's quite obvious, and it's reactionary rather than preventative. Western biomedical approaches to health focus on a deficit-based model, the absence of disease, versus a culturally based model which looks at the holistic approach to health, the mental, physical, emotional, and spiritual. So a new Indigenous framework has been developed by the First Nations people in Saskatchewan, and we believe it's the key to improving Indigenous health and wellness. Indigenous culture is a huge component of this. One of the things I want to stress is that I sometimes get nervous about using the word culture because we know that a lot of our communities have been impacted by Christianity, and so there's a disconnect sometimes between culture and Christianity. But if you look at culture more as embedded in language and land, then it's not as threatening to some as it is to just impose the idea of culture on people. One of the solutions must reflect what we call Mio-Makotawin, which is the Indigenous concept of health. I've mentioned this already, and I'll mention it again and again because it's a key factor. I think that the biomedical model of health really focuses on one thing. The Indigenous or cultural components of health are spiritual, they're emotional, they're mental, and they're physical. We did a study a few years ago with Aboriginal youth who identified that someone may look very healthy, but they may be drinking all the time on the weekends. So that person would identify that the health is a lot more than just how one appears or that there's no disease present. One of the things that I would like this talk to do is to really talk about how to avoid problematized and deficit-based thinking. I always thought this was a common concept, strengths-based versus deficit-based. And recently I learned a huge lesson with some of my research team who consists of epidemiologists and doctors and nurses and all types of other researchers. They did not know there was a difference between deficit-based and asset-based measures. So I won't go into a lot of detail on that, but one of the things that I'll say is that, so a measure of anxiety and depression would be a deficit-based measure from an Indigenous perspective. A measure of post-traumatic growth or resiliency would be an asset-based measure. And so one of the things we want to avoid are these problematized and deficit-based ways of thinking. Terms like closing the gap is actually a deficit way of thinking. And it is because Indigenous health is being measured against non-Indigenous health. And likely the only way the gap is going to close is if non-Indigenous health starts to fail, not because Indigenous health is increasing. So we want to look at strengths-based approaches to facilitate wellness by building pathways to resilience. One of the things that's extraordinarily important is understanding the role of the colonial context. And sometimes I make assumptions that we would all know this, but as my friend Dr. Shawneen Pete always says, is we've all been structurally denied the opportunity to know the truth. One of the things that we have a struggle with when we talk about reconciliation is we often leave the word truth out of that. And so if we can't be in a room and listen to the truths of the people that went through the horrendous history, we're not going to be able to move very far. And this is where I find a lot of resistance comes in, is when I come into a forum to speak and I start to tell the truths. If someone's been structurally denied the opportunity to know the history, there's often some anger, some guilt, some shame that emerges. And so when we're doing work with Indigenous and non-Indigenous people, sometimes if non-Indigenous people are learning this for the first time, they have to actually leave that environment and go do their own work, their own decolonization and learning of history, so that we don't disrupt the Indigenous work that's going on. The history of Canada's Indigenous peoples, as hopefully many of you would know, is pretty traumatic. One of the things that I know is I may be Ojibwe, I may be First Nations, I'm a half-breed, but when I go into any community that is not my own, I am relearning all over again. I have to relearn their history, I have to learn their impacts, and so that takes a lot of time. Doing work with Indigenous peoples is not a one-size-fits-all, and it is not an easy thing to do. You have to really understand the context of the particular community, if they're more traditional, if they're more Christian, if there's a mix in between. You really have to understand the nuances of what it's like. And it can be a little bit daunting for people because they themselves haven't even thought about these things, and then they're being faced with this unknown world. So I believe that the colonial context is a very important piece to understand when working with Indigenous peoples. The trauma of colonization in the residential school system remains embedded in the lives of Indigenous people today through direct experience and intergenerational transmission. I hear often, why don't they get over it? Why don't they move on? But the reality is that we are stuck with a historical trauma that has been compounded, and it's very complex. And we haven't even begun to unravel how to provide treatment and healing and wellness to these populations. Without reparation and healing, this trauma is compounded by racism and inequity in health, education, governance, and policy systems. Indigenous peoples suffer from endemic poverty, and attitudes towards health further compound these barriers from the earliest age. However, I'm very excited that the first ever quantitative evidence reveals that recovery from colonization is grounded in cultural healing practices, for example, land, language, ceremonial, and teaching practices. This is a first for us, as we know that we have a lot of evidence in our own culture and in our own ways of knowing that traditional ways and practices work. But for the first time to have quantitative evidence in such a Western-based world is very, very important to us. It's actually the Fidelity article that's cited here, and it's a really good read as to how they went about creating this study. I'd like to talk to you a bit about the structural determinants of health. I think this is a bit of a complex, I teach this in my classes, and it's a bit complex to understand. I'm just going to put these all up here. So one of the things, if you look at this tree and you start at the bottom of the tree, not the top of the tree, and you look at what affects people's health and its historical, political, ideological, economic, and social foundations, those are the things that affect all of our health and well-being. But one of the things we have to really understand is that if we focus on the roots, we need to look at Indigenous people and the root causes of problems that they have today. So at the root, if you look at the historical and political and ideological, what happened to First Nations people was there was a disruption. And that disruption looks like a disruption of worldviews, a disruption of practice of culture, a disruption of the ability to be at home with their families. They were taken out of their communities, they were put into residential schools, and their entire ways of knowing were taken away. And when you look at that as your root and you move into the intermediate determinants of health, the problems that you have for Indigenous people, it means that their kinship ties were disrupted, their relationship to land, ceremonies, their knowledge sharing was disrupted. And that manifests and looks like poverty, illness, domestic violence, and addictions. So when you start to look at the leaves of the tree and you see the poverty and all these other aspects, what we do as healthcare providers and practitioners is trim the tree. We trim the leaves, but we're never getting at the root problem, which is the structural determinants of health, the root causes. So until we start addressing the root issues, we're never going to do anything but trim the tree and have the same consistent problems we always do. I think this is really worth thinking about. One of the things that I insist on is identifying colonialism as a social determinant of health, a structural determinant of health. When we interrupt the access to land, when we interrupt the experience of people, when we disrupt, bring in foreign diseases, and then put dependency on Western medicine, when we have residential school and policies that mean we can't even leave our First Nation without a pass, we lose our language, and then we have this trauma that we pass on to our children. These are things that are playing out in today's society. So it's not something we can really just get over. It's something that needs to be addressed at the core level in each and every community. And each community is unique and different on its own. The result of the past is that there's a great deal of work to be done now to right these wrongs and to build trust and meaningful relationships with self-determining Indigenous communities. I believe we all have a role in the process, and the TRC calls to actions identify this. So one of the things that our research team tries to stress is that this is not a problem to be fixed. These are relationships to be repaired. The history of Canada is about bad relationships that need to be repaired, not Indigenous problems and people that need to be fixed. So we'll focus a little bit on what that would look like and how do we establish authentic relationships with Indigenous people and what that really means and what that looks like. Our question really needs to change from how to work with Indigenous people to how can I establish an authentic relationship with Indigenous people. That is the way to engage in relationship and that's the takeaway from today. We need a new perspective to face challenges. We need to start looking at some of the roots of that tree, the structural determinants of health. We need to start by understanding a different worldview, and this will cause discomfort. One of the things I say when I do talks on reconciliation is that if you don't feel discomforted, you're not actually reconciling. From a lot of our perspective, reconciliation is the atonement. And when you're atoning for something that's gone wrong, it doesn't always feel good, but the outcome is a healthy outcome. I can give an example of this. I have a research team that is mostly non-Indigenous simply because we don't have the capacity for Indigenous researchers in specifically Regina area. And so I had an engagement session with eight of our communities, and we were at a long board table, and all the community members sat on this side and all the researchers sat on this side, and I sat in the middle, and I found that quite interesting that I was just divided right in the middle. And so I felt like I was translating consistently, and one of the things that the community said, we were doing HIV testing with their communities, and they said, we don't want any more deficit-based measures. Of course, I just talked to you about that. So I said, yeah, absolutely, let's pull out these measures. And my epidemiologists, my physicians, and my nurses did not know the difference between deficit-based measures and asset-based measures. So I was stunned by that because that's just so common in Indigenous ways. And I assumed even the language would sort of identify what that meant. But my team didn't understand it. So I have a lot of work to do within my own team on teaching them that it is not okay to ask certain questions or to always look for anxiety measures and stress measures, that the communities really want to know how they're doing and how their wellness is improving, not how much sicker they're getting by day. So I would ask you to think about a relational worldview. A relational worldview is a perspective that allows us to humanize the world around us, to break down that barriers in the colonial thinking. One of the things that is a real stretch for people is to think about the universe as a co-partner. Everything is alive and can be engaged. So we do a lot of land-based therapies with our work. Someone asked me today what that means. So what that might mean is we might take a group of people fishing, we might take a group of people hunting, we might have a Sundance Lodge. I can't tell you how many therapeutic sessions, I'm a counselor by trade, how many therapeutic sessions have occurred while picking berries, while being under the Sundance tent, just taking a break. I've had a lot of, I bring students along on these trails, and I have seen a lot of therapeutic growth in students understanding that therapy isn't necessarily in a room with a table and a counseling chair. So I think we need to think about these new ways of knowing and these new perspectives on how to move forward. Indigenous people believe that a relational way of being is at the heart of what it means to be Indigenous. I find it interesting that I can't go into any community and do work. I have to be brought in, I have to build a relationship, and then I might be able to bring in some of my team. But if you don't have the relationship, you're not going to get in. And so it's difficult because it takes so much time. And I remember when I was working in the north of Manitoba, I might fly into a community and have to spend 3 weeks before anyone speaks to me. And if we're writing grants or we're doing research or we're doing things that take time or are very time sensitive, you can't just explain that no one's going to speak to you for 3 weeks because you haven't built that relationship. So it takes a lot of time and it takes a lot of know-how. I've adapted these from research, but I call these the Indigenous Relational Accountabilities. I think the Indigenous communities that I've worked with find these extraordinarily important. The respect of Indigenous cultural identity is key. The relevance to the Indigenous perspective and experience. Reciprocity in relationships and in knowledge sharing, and I want to give an example of that reciprocity piece. So when we ask for something from Indigenous communities or we want to give something, there has to be a reciprocal relationship. So for example, one of our communities created their own ethics, and it's a beautiful document. And we have 7 other communities in which we would like to have that similar document. But we can't take that document from this community and just give it out. There has to be a reciprocal exchange. So right now we're in this process of determining what the community that has the ethics would want for that exchange, whether it would be money or tobacco, or some type of offering that would be an exchange. When you hear about the offering of tobacco to an elder, someone asked me last night, well, why do you do that? Why do you give tobacco to an elder from this treaty area where we're from? And it's because when you ask something of someone, you need to sacrifice yourself to give to that person to get back. And so if the person denies your tobacco, it means that they can't do what you're asking. So when you think about that reciprocity, if you're asking your patient to give you something, what are you going to give in return? If you're asking for personal information, is there something that you can give of yourself? Could you tell a little bit of your story? Could you make yourself a little more human? Think about that reciprocity in that relationship. Another thing I said to my research team at that same engagement session was responsibility. Especially in Saskatchewan, you think that we're only 1 million people. One of the responsibilities that I have as a researcher is if I build a relationship with this community or a person within the community, that's a lifelong relationship. When my grant ends in 5 years, I'm not popping out. I'm not leaving. In fact, I'll probably end up staying with that community and writing an additional grant or writing additional supports or interventions for them. So when I said to my research team, and some of them flew in from McGill and BC, I said, you have a responsibility here to these communities for the rest of our lives. And they started laughing. The whole team busted out laughing. But it wasn't funny. It's true. It was true. And the Indigenous people were nodding their heads. And so there was a real cultural disconnect for a moment when the realization came that I might have to stay committed to this group for the rest of our lives. And so that's a worldview difference that, again, I talk about that discomfort. If you want to work with Indigenous people, it's not a one-off. It's not a one-time. You're not going to helicopter in and helicopter out. You have to really think about, especially in Saskatchewan where we're such a small community, think about that capacity building and that community building. If you're a nursing community, become a part of that community. Become a reliable person that, in many ways, when our team does build the relationships, we become embedded in the community. We become members of those communities. We're relied upon. And our goal is to always work ourselves out of a job. So maybe the community doesn't have capacity in this area, but we can build it up with their own people, and then we can get out, and all we have to do is be a support on the sidelines. And this is where the culturally responsive framework comes in. The culturally responsive framework, I just want to give a little bit of history about it, the development of it. It was developed by a memorandum of understanding between the Federation of Sovereign Indigenous Nations and Health Canada and the Saskatchewan Ministry of Health. And this was an important moment in August of 2008. The culturally responsive framework, there's actually a paper that we've written on the development of it, so you can get a lot more of the history of it and how we did engagement and consultation. It's entirely Indigenous-led, so the FSIN led the engagement sessions for 3 years with community, came up with the culturally responsive framework, and then Indigenous scholars were asked to enliven it into a theoretical model. To this day, I've never, ever seen anything in North America that has started at the ground level and come up through the academic ranks with all Indigenous people. So this is why I believe this is a very important framework for our communities. The purpose of the culturally responsive framework is to ensure that health services available to and accessed by Saskatchewan Indigenous peoples will be respectful and accommodate their unique cultural practices and beliefs. The CRF aims to help organizations improve healthcare experiences of First Nations patients and clients in provincial care facilities and institutions. It focuses on ensuring their cultural needs and differences are understood, accommodated by healthcare providers in all aspects of health. It draws on the collective wisdom of First Nations elders, knowledge keepers, and leaders at the community level, alongside provincial First Nations leadership, scholars, and health practitioners. That may not seem like a big deal, but I'm only a third-generation PhD. So this is a huge deal that we now have Indigenous PhDs who can work alongside Indigenous health practitioners and Indigenous leadership to do this work. Together, we are working to challenge the assumptions of the privileging of Western ways of knowing and intellectual practices. We have our own intellectual ways of knowing, and for the first time, this model is one of those ways that we're getting that information out there. And you might hear me interchangeably call it the CRF and the ICRT, because the ICRT is the theoretical version. But this model was created and owned by First Nations peoples living within Saskatchewan's borders, and the fundamental principles can be applied locally. You will hear me speak more specifically on First Nations versus First Nations, Métis, and Inuit, simply because the consultation itself was only within Indigenous First Nations communities. It was the First Nations leadership. So I can't speak for Métis communities, although they know the CRF exists. It is locally adaptable and it has worked in all areas, but I just want to be clear that why I'm not including Métis in some of this is because they weren't involved in the engagement processes. The CRF came up with 3 strategic directions. These are the 3 strategic directions that our network is founded on, and these are the ones that I believe will get us moving forward in this province. The first one is to restore First Nations community-based health and wellness systems. It sounds easy enough, but when you look at the disruption that we've experienced through colonization, many of our communities have lost their own ways of knowing when it comes to this. Some of our communities don't have access to their traditional medicines, and each of these things were protective factors along the journey. So if we have sweat lodges or we have very concrete teachings during pregnancy, what we're supposed to do, how we're supposed to behave, and those protective factors have been taken away, that's why we suffer some of the social ills in our tree and our leaves, because we don't have those foundational root determinants anymore. The second is to establish a middle ground for engagement between mainstream and First Nations systems and worldviews. What I love about this is that Indigenous ways of knowing, now anyways, never are for Indigenous people only. there's always a consideration for the entire world in which we live. And so that middle ground is for establishing those connections between Indigenous and non-Indigenous ways. And the third is to transform mainstream service delivery to be culture responsive by guiding research that improves Indigenous health. So how do we achieve culture responsiveness? So the first one, and I would encourage you to look at the CRF online at the Federation of Sovereign Indigenous Nations website, because it actually has some very tangible, concrete things that you can do, or that you can do with other people as allies. So the first objective to restore the health and well-being is to revitalize First Nations languages. Now that's not anything any one of us can do, but we can certainly be allies in the process. Support languages coming into your health facilities, support the use of language, get translators to come in. Nothing is more scary for a person coming out of a geographically isolated community who only speaks their language to come in and have to get some medical test in a city that they may have never gone to, coming in by themselves. Now we don't even have buses anymore, so how they even get here is a consideration. And then to be gone into the speaker earlier this morning talked about one of his patients just saw the hospital and didn't even want to go in. So imagine coming out of community by yourself on a bus or whatever mode of transportation, coming into the institution, not speaking the language, and then having to navigate your health care. It's a pretty intimidating process for many people. The second objective would be to teach the medicines. That's not for us to teach the medicines. That's for us to support the teaching of medicines within the community. And the third objective would be to restore First Nations ceremonies as the source of education and health in First Nations communities. One of the things that I spend a bulk of my work on, and it's unfortunate because my preference would be to be in community working with clients and supporting the HIV work and the chronic disease work that we do. But I often find that I work in this area, and it's probably because I'm educated. I help to, like talks like this, build relationships and partnerships between and within First Nations and mainstream systems. I'm often that one that navigates the language between what's going on in the Western way and what's going on in the Indigenous way, and trying to find that middle ground. Some of you may have heard of this middle ground, or you might also hear it called the ethical space by Willie Ermine. He speaks of that. He's an elder from Sturgeon Lake. But this is where the work is going to start. And we're not going to get anywhere if we don't establish a middle ground. And the third strategic direction is to transform mainstream health service delivery. So that can be done by fostering education and culture responsive healthcare, developing culturally competent and safe policies and programs, strengthening First Nations health workforce. So how many of you have Indigenous colleagues? I think that's one of the biggest problems we have, is people always ask me, well, how do we do this work? And I say, talk to your Indigenous colleagues, and they don't have any. Then I would suggest that's the first place to start. Start recruitment programs, start working with youth to get them into the healthcare system so that they can build their capacity and become the doctors and nurses of the future. If we don't have our own people working in the systems, we're not going to be able to make that much change. And one of the things that elders did say when they created the culture responsive framework is that change is going to come from within the health systems itself, by the people and the policies that work there. So it's not going to be Indigenous people changing it. It has to come from within the systems itself. And the fourth would be to create space and health service delivery for Indigenous knowledges and approaches to health and wellness. And I want to just mention on this one, it sounds good. And for example, Regina General actually has a smudge room, a ceremonial space. But when I gave birth to my child, I wasn't allowed to take him off ward to get into that ceremonial space. So if we can build these spaces and places, but if we don't have access to them, even though they're there, it really doesn't do much for us. What are the benefits of culture responsiveness? Well, one, we know that consumer health literacy is reduced and is increased, and reduced delays in seeking health care and treatment because you're less intimidated to get treatment if it's culture responsive. Communication and understanding between health consumers and providers are resulting in better compliance with recommended treatment, clearer expectations, reduced medical errors and adverse events, improved satisfaction, reduced hospitalization rates, patient safety, quality assurance, business practice, and best use of resources. The lack of culture responsive care is, in fact, a major contributor to health disparities. I just want to spend a little time on the middle ground for a moment and how we create the middle ground. So the first step is likely to say, because I'm likely to say in this slide terms you don't know, and so my recommendation would be, if I do say that the area for you to deepen your work would be to use this as an opportunity for growth. And if I'm saying things that you don't understand, that you might want to seek out either a non-Indigenous ally or an Indigenous person to help explain some of it. So one of the things that I already mentioned was this ethical space. So Willie Ermine out of Sturgeon Lake has identified this as a cooperative spirit between Indigenous peoples and Western institutions in order to create new currents of thought. It's supposed to be the space where the two worldviews can come together and begin to have the conversations in a safe way. And we partner that with this concept called two-eyed seeing. Again, these are terms, if you don't know, there's a lot of literature out there, and I've cited some of it, and you could Google it as well. But the Canadian Institutes of Health Research has actually adopted two-eyed seeing as one of their models and approaches for Indigenous wellness. With two-eyed seeing, you see the strengths of Indigenous knowledge and the strengths of Western knowledge, and you use them together. And so if you create that middle ground space, which the culturally responsive framework would suggest that you do, and in that middle ground, my PhD student, Carrie LaValle, has actually, we've actually taken this one step further. So when you create that middle ground perspective, and you have your Indigenous and non-Indigenous people in there, what we suggest is that you position Indigenous ways first. So whether the community wants to open in a smudge or prayer, or sometimes our communities want us to come in a night before and do ceremony and not even do any work until the next day, that you honor and respect that way of knowing. And then when you're in the middle ground, and this is where I sort of take a little bit of a leap between the ethical space and two-eyed seeing, is we suggest that you harmonize. And so you only use evidence-informed Western practices, first of all. So you don't just bring any old Western approach. You use the ones that are evidence-informed. And then you harmonize it with Indigenous ways. And if it doesn't work, you throw it out. So that may be a shock to some, because maybe a certain medication works, or maybe a certain therapeutic approach works, but if it doesn't harmonize with Indigenous ways, you discard it. And you respect that discarding, because for that particular community, it just may not work. And here are some suggestions that you could do for yourself for middle ground actions if you want to take some action yourself. Would be to host regular gatherings that bring together health partners to discuss responsive care. And I would suggest if you're in a health area, you could bring in local Indigenous community partners as well as your hospital partners or the people you're working with. And then you feature promising practices in the area and explore opportunities for potential partnership models. And promising practices might include traditional medicines and ways of knowing and traditional ceremonies. You can establish or strengthen agreements that formalize partnerships between First Nations communities and organizations and mainstream health systems that deal with shared roles and responsibilities. That should be really clearly outlined what those roles and responsibilities are. And I believe right now we need to establish an independent body that Indigenous patients and families may address their healthcare concerns and mediate issues between the two systems and ways of knowing. This work comes from Dr. Angela Snowshoe and Noel Starblanket. One of the things that we do within the culturally responsive framework and in the middle ground itself is we have these 4 protective factors. And we believe that when you apply these protective factors, you are decolonizing the healing process itself. And the reason they're presented sort of intertwining is because they happen concurrently, and they happen separately, and they happen all over the place. So I'll just explain these a little bit. So from the middle ground, we need to move forward with the key protective factors. Specifically, this model is really good for healthcare, but it can be applied to other disciplines. It's worth noting that some would say that this is just inherently the middle ground anyway, but what we find is that when you identify the protective factors, so you talk about what you're doing that's spiritually grounded, what you're doing that's community specific or trauma informed, that you're actually identifying that process, and as you identify them, and you strengthen them by articulating, hey, this is what we're doing in this process. So you're not just assuming that it's there. So for example, if you engage in ceremony, if you open in ceremony, that's a spiritually grounded approach. It's also community specific, and it's strengths based. So you're kind of overlapping all of those things. So I'll go over these in more detail in just a moment. The culturally grounded perspective looks at cultural connectedness. To be spiritually grounded, you need an Indigenous worldview, you need the whole holistic view of wellness, which we've talked about already as the mental, emotional, spiritual, and physical, not just the deficit model of absence of disease. That you looked at the kinship connections to family, community, and the land, the use of ceremony, integrating traditions and culture. I know people struggle sometimes, especially urban people who don't understand the connection to the land. And the best analogy I can give is that, and my son, who's 6 years old, is really bright. He got this concept pretty well. So we buried his umbilical cord in the land on our reserve near the lake. And he's 6 years old now. We did that but when he was about 8 months old. And so now he knows that that is disintegrated into the land. And so we talked about last summer, because we have a cabin here and the lake here, and his placenta was buried up here. So I said, where in the life cycle, my son, do you think your umbilical cord is now? And he believes that it's disintegrated already and that it's headed to the water. And probably by next year, it'll be in the water, evaporating to go into the clouds, to rain on our land and to come back. See, he already understands that cycle of life. And I don't think I really understood that concept till I was in my 30s. Even though I understood things to be connected, I didn't get it in the way he gets at 6. So I just find that a beautiful way of understanding the connection to land. Because when people try to tell me, well, you can just move or relocate, which we've been done numerous times, they often say that they don't understand that I don't want to relocate. My son's umbilical cord is buried here. We have an attachment to our land in ways that people often just don't understand. Community-specific perspective, I've already given a couple examples of that, but it's the ongoing transformation of identity. Some groups have done really well. The health of the community appears to be linked to the sense of control and cultural continuity, and we support initiatives that follow the vision of the unique community based on the project, the community needs, and the community's capacity. And for me, I do speak from a research perspective, and one of the things that I know, for someone who's Western trained like myself, is that often that's a very strong paradigm shift for a researcher to go into community and be told that they want to do it this way when you think and know it'll work better that way. And one of those examples would be recently we're getting ready to build a healing and wellness center in a community, and it's an opportune time to also put a primary health clinic in. But that community doesn't want a Western-based approach to health in their new wellness center. And so even though all of us are sitting back saying, but even me, the community doesn't want that. And so rather than sit there and chip away and impose that, you have to respect where the community is and let the community control it. And that is a foreign concept, because so many times in all of this history that I've gone over so far, we as Indigenous people have been told what's best for us. We've been told what to do. The resistance and the rub is coming now with this reconciliation movement is because First Nations people are asserting their rights. They're asserting UNDRIP number 19, the duty to consult. They're asserting that we have the ability to speak for ourselves and do for ourselves, and we are asking non-Indigenous people to be allies in that process, not to lead the process. Now, we don't have a lot of leadership, say, in research or in certain areas, but that's where then you identify capacity gaps and you start to grab some Indigenous students and scholars and you start to pull them up the ranks. I had a team come in from BC who made a few major mistakes in Saskatchewan and were called out in the media on it, and it caused a big kerfluffle. And then they came to me and said, how can we atone and how can we fix this? And I said, first you have to do your own work, which is some of the work I've already mentioned, but the second part is you have to, in your health facility, in your med school or wherever you are, get some Indigenous students in there. Because if you had Indigenous community members or Indigenous students from the communities that you're working in, you wouldn't make some of these protocol breaches that you're making, because you'd be informed by community members. So those are the things I think are really important, is if you don't have any colleagues around you, start getting them, and you're going to get them from the youth. This one's a very good one, and I think this does not even have to be Indigenous specific, having a trauma-informed perspective. This is so important, and one of the things I want to stress about this one is that it's not just understanding what trauma-informed is and hearing about it today for the first time as a concept. It's actually going out as healthcare practitioners and becoming trained in trauma-informed care and practice. I consider this an ethical responsibility for all of us working with any human that has experienced any type of trauma. Not Indigenous specific, but will help all people because it's holistic. So there are ways of knowing that are trauma informed, and I can just give a brief example. So if you're in a school, you're a teacher, and you've got Johnny, he's had this bad day, runs under the desk and he's hiding. Some teacher might come and say, Johnny, get out from under the desk, go join your classmates. Johnny, get out. If you don't get out, you're gonna go to the principal's office. And just start scolding Johnny for misbehaving and being under the desk. But a trauma-informed perspective might say, Johnny, what's going on with you? Do you think you want to just stay here for a while and take this time till you feel better? Would you like me to find a better place for you? Do you feel safe in this place? Why don't you, here's a red ball. Why don't you put the red ball on the desk when you're ready to talk, and I'll come get you, and maybe we can find something else for you to do. Do you need to go bounce a basketball for a while? Do you need to go for a walk around the track? Those are types of things that are trauma-informed that would help Johnny versus sending him to the principal's office or punishing him for going into the desk. That's just one example, and that's not enough of an example for you to be a trauma-informed practitioner. So I would highly recommend a lot of training in this area. Practitioners must take into account the historical and intergenerational impact of colonization and its associated negative health impacts, as you saw the tree and the leaves on the tree. So one of the things that I say is, I went to a psychiatrist once when my brother-in-law committed a homicide-suicide, and she was an African woman. And I told her what happened on our reserve and that it was the community was being affected. And her first comment to me was, "But you look white." And I said, well, geez, because I look white, does that just negate my entire life experience and my family's experience and our community's experience? So I think that there's these ideas of how we look and how we're supposed to be and how we're supposed to act when we're First Nations or non-First Nations. But the reality is this is our experience, and not to discount it just because you think we should be over this trauma. I'm not over this trauma. My son's father suffers from addictions because his father went to residential school and he suffered from addictions. So my son is still going to have the impacts of this, and we do our best to mitigate it, but this is the reality of where we are in the world. So please keep the trauma-informed perspective in mind. We've talked a bit about already the strengths-based perspective. What I love about this is that, first of all, let me clarify that strengths-based does not mean ignoring historical and current social realities facing First Nations, Métis, and Inuit peoples and the associated negative consequences to focus on positives. I often get challenged on that. That is not what this is. This is strengths-based health promotion, which facilitates wellness by building the pathways to resilience. So attempting to identify the resources that an individual or community already has to address problems is a model that focuses on developing assets. As people develop greater awareness of their own strengths, they will be able to take control of their lives and make appropriate decisions to empower themselves, always looking for opportunities for growth. So the culture responsive theory or culture responsive framework may be viewed as a viable strategy to improve the links between access, equity, quality, and safety, and better health outcomes for culturally and linguistically diverse populations as a strategy to enhance the cost effectiveness of health service delivery. I would say, and some scholars are just now learning, that we have an Indigenous hospital out in File Hills. And one of the things they're finding is that the non-Indigenous patients who go there actually have better health outcomes because it's a holistic hospital versus just the Indigenous patients that are getting their health met too. And that's why I really stress that even though this is an Indigenous way of knowing, this is really a better way of knowing for all people. And again, Indigenous people always think about moving forward in the future. So we don't just think about our way and what's best for us because we live in a wider world. We think about what's best for all people and how to move that forward. I only have a little bit of time left, but I just want to show you this slide about, so on the left, you'll see a picture of a typical primary care facility. And then on the right, you'll see the Nanataweha Wikimik Healing Lodge and Wellness Clinic, which is at the Faculty of Education. It's in the Indigenous Counseling Program at the University of Regina. And I actually built this lodge with Dr. Angela Snowshoe. And we had a SHERF grant in which we examined the elements, the concepts, and the processes needed to create an Indigenous healing space that allows Indigenous healing practices to be integrated into the counseling setting. The project was based on the premise that places are not neutral, they are alive and impact relationships. So everything from the rocks on the wall to the art to the floor, the star quilt on the floor, which you can't see because the chairs are there, were all thought of, done through ceremony with elders and guidance from elders, and the community members picked every component that they felt would make them feel safe to have therapy in there. So what you are looking at is the group counseling space, but if you notice there's a door, there's 4 doors surrounding there, and each one of those doors is an individual counseling space, and that's where we teach our group counseling and individual counseling classes. It's a pretty amazing space. I've had other meetings in there as well. I had the SHERF Board of Directors, Saskatchewan Health Research Foundation Board of Directors meeting in there, and the president came to me after and he said, I was really scared. I had to get my budget passed today, and I thought it was going to be brutal, and he said it passed with ease. So we think that there's lots of things going on in that space that are healing that even non-Indigenous people feel when they go in there. So some questions I have for you is, how do you engage with community? You can engage community in multiple ways: the individual level, the professional level, through health, staff, resources, tribal councils and organizations, or at the political level, chief and council, Federation of Sovereign Indigenous Nations, the Métis Nation, etc. It's like any other relationship. People often say, well, how do I do this? And I would say, well, like a relationship. How would you meet someone? What would you say to them? What would you ask them? What would you do with them? How long would it take? I'm just going to jump to, I'll just address this quickly. One of our elders, Peter Nippy, says that if you cut corners with ceremony, it will show that you will cut corners with everything else. So I always keep that in mind, because sometimes you think, oh, well, we didn't have ceremony, so we have to go do this engagement process because the deadline's coming. If you cut corners in ceremony, you'll cut corners in every place else. And he stressed that to me, and I keep that in the back of my mind. I'm going to make this my last slide because we're running out of time. Again, to do anything Indigenous in an hour is pretty difficult, but this is really designed to be a full day module. So if you feel like this is something you want to do to deepen your work, you could look for our network to have the full day workshop. But I really like this slide, and I think this slide could support you in your work if you want to do this type of thing. One, if you look at a planning process and you think, did you include time for relationship building, community engagement, and ceremony? Did you include a budget for things like tobacco, cloth, compensation? And those are things, again, if you don't know what those things are, this is work that you need to do to understand. Do you know what the community has for supports, what they already have? Is it possible to do an asset map? Transparency. Does the community actually understand what you're doing? That's a huge one. We think we know and we're telling them, but if they don't understand what's going on, it's not a benefit. Have you added space for community input? And one of the things I always say, even when going through a survey and wondering, is this survey appropriate for our communities, I'll say on a specific question, how does this benefit community? I might say it after each and every endeavor that we do. I will turn to my research team. Okay, you want to use this measure? How does it benefit community? If we can't have community tell us how it benefits them, it probably isn't something that they feel is useful and likely wouldn't have uptake anyway. So these are just important considerations when thinking about the future. This is what a healthy tree would look like, with the relationships, the middle ground, the protective factors, cultural humility, the Indigenous worldviews, and knowledge. So think about that healthy system and that healthy tree and how you might be able to get there in your work. And then I also just have a place in here where you can deepen some of your work. Sometimes I call it homework, but I like to say deepening your work. There's some resources there for you. And if you want to cite anything from here, I have given this talk, so if you want to use this in your own work, there's the citation at the end. Thank you.
Thank you for your informative and thought-provoking presentation, Dr. Sasakamoose. We have had some questions come in by text, and so I'll just remind people what that number is so that they can text in. We're going to have questions for Dr. Sasakamoose, Dr. Newstead Angel for the next few minutes. The number for texting is on your screen. I'll first again start with asking our studio audience if there are any questions at this time, and if so, to step to a microphone, introduce yourself, and identify the speaker you're directing your question at. In addition, if you're not comfortable stepping to the microphone, then you can also text your questions in, and they'd be quite welcome. Anyone at this time? Okay. Now, I've kind of been thinking about how we can manage this. I've got some very clinical questions and then some more general questions. So I think what I'll do is I'll just go between you. And I hope it might be a little disjointed, but at the end they'll say, well, she made the wrong decision, but anyhow, there we are. We got the questions answered. Dr. Newstead Angel, how are blood sugar and A1C targets set postpartum in a woman who has pre-existing diabetes and a woman who was diagnosed with diabetes in pregnancy?
So those with pre-existing diabetes, they would have the same A1C targets as any non-pregnant person, so an A1C of ideally around 7%. Again, I give people a little bit of leeway that first year postpartum, because we do know that A1Cs do go up postpartum because they're having now to look after their diabetes plus look after their baby, and it's a lot more difficult. So I give them some leeway and say you're doing the best that you possibly can, and that's great as long as you don't go from 7 to 11. But if they do, then we kind of have to look at what is going on in their world and how can we improve things that way. For those that have had gestational diabetes that don't have underlying diabetes and their screen postpartum is negative, then they would just have the same. They don't need to have target A1Cs done at all because there's no need for that. If they do screen that they're a pre-diabetic, then again be routine screening for underlying diabetes every 3 years to do so. And target-wise, again, target sugars for the pre-existing diabetic who's not pregnant, we usually say 5 to 7 for fasting, 7 to 10 after meals. Again, I always give them some leeway, saying those first 6 weeks is very tough as you're getting used to breastfeeding and your new baby and trying to check your sugars. So we understand how difficult it is, and so I'm a little bit more lenient with them because I want them to avoid lows and just bond with their baby. And I know it's a lot of work for these individuals, and we've had many comments that people with diabetes and pregnancy, it's really just a full-time job at the end of their pregnancy between their appointments with the clinic, with their obstetrician or their other care providers. It's a lot of work for them to do, so we acknowledge that's a lot of work and just continue to support them.
So you really personalize it in terms of the assessments that you've done and the values that you find on further testing.
Right, yeah.
Right. Yeah. JoLee, you've discussed the importance of reciprocity. Can you provide some suggestions as to how I, as a healthcare provider, practitioner, can work with First Nations persons with diabetes who could benefit from lifestyle changes to manage their diabetes?
Are you talking about on one-on-one?
Yeah, one-on-one, yeah.
I think that, it's kind of interesting. We had, the hard part, I think, is when they come out of community. If they're in community and they come out of community and they don't have the support back at home. So one of the things that, again, I sit in that middle zone. So I often in our community, when the doctors are hosted, I'll go hang out with the docs at the health center. And then, but then the community's there, so I'm with community. But then after I hear the docs debrief, and they'll say, I can't believe X person didn't get their medication refilled for 3 weeks, or I can't believe this. And just that morning, I heard Granny say, I can't get my medication filled because the taxi's broken down, or this happened, or no one can give me a ride because she doesn't drive. So I think it's understanding that it's not necessarily always a failure or an unwillingness to participate, but the lifestyles are really different. And so trying to figure out what support mechanism might be useful. Would it be a call? Would it be, I'm just learning now that pre-packing the medications in those daily packs, I mean, I'm not a healthcare practitioner in that respect, so I don't know, but the nurses are finding that really helps. So there are things that I always ask, is there anything I can do to support you in this journey and find that? And the other thing I would say is if they are using traditional medicines to support that, because I think that some of our communities do have medications for diabetes, traditional medicines. And so just knowing that those might be paths that they want to take and that they want to try and being supportive of that. I have used traditional medicine a lot, especially during pregnancy. And so one of the things that I faced was a doctor who was a bit resistant to that, but then my personal doctor was completely supportive. So I think that there's ways in which that you can support the person, but also identifying what is preventing them from engaging in care in the way that they need to. And if it could be as simple as transportation and getting meds refilled. So it's so many barriers that are happening. And the same thing with urban people, right? Just not access to care, not access to the same types of things.
Just to follow up to that question, so Dr. Dawson had mentioned the importance of supporting people to exercise to their limits of tolerance, and had mentioned, is there a hiking group? Is there group activities in the community? Can you comment on any of that?
Every community is different. Every single community has a different infrastructure and different everything. So I don't think there's a general thing at all. Some communities have really good sports program for their youth and some have none. So it really will depend on where they're located, what their funding structures are like, what their chief and councils are like. Yeah. So there's really no one size fits all.
I recall when I worked in home care in Saskatoon, there was a walking group at White Buffalo for women. But there was no transportation to get there, so they had poor uptake of the program. So what was missing in that initiative? Because it's a good initiative, but tell me what we were missing, or not we, but what was missing.
Well, I'll just give an example. So we run therapeutic groups for Indigenous women who have survived intimate partner violence, and we run it in Moose Jaw, Regina, and Prince Albert. So in order to do that, we provide child minding, we provide a meal, we provide transportation to and from. So that is a huge expense, and most agencies, health facilities, doctors don't have that kind of support system in place. I'll give you another example. I work with a few of the methadone doctors in town. There's no methadone recovery programs in Regina. There's not one support group in Regina. And we don't necessarily want the 12-step model, which is, getting off methadone. It's more, how do you just support the daily living? So I think that when we wonder why things aren't working, it's because there's a gap. You probably don't know what the gap is. And the best way to figure it out would be to talk to your clients and find out, what supports do you need to be successful in this? What assets do you already have in your home? That's key. I mean, how many times do we have people go to get treatment for addictions and then go back into community to relapse, right? Because there's no supports in community. So identifying what supports they already have and building on those are key too.
And of course, I now have another question because you talked about asset mapping. Are you aware of a tool that's available for frontline healthcare providers to use
No.
for asset mapping?
No, but I would love that because one of the things, so our network is new, and I've had my research team and Dr. Skinner's had his, and we've melded now, and so that is the next approach is asset mapping in all communities, because I think that that's been a gap as well. It's just not understanding the resources available, and it also helps community take pride in what they do have to offer.
Yeah.
And one of the biggest gaps that we have in some of our communities is knowledge keepers and speakers now, right? So we're getting really down to the wire of having speakers and elders in our communities that are still alive and still able to knowledge share.
Okay, thank you. Dr. Newstead-Angel, if insulin is required, what are your thoughts on long-acting basal insulins such as Lantus comparative to intermediate-acting insulins such as Humulin N once daily or twice daily?
So in pregnancy, they can both be used. I always, again, look at what I'm sort of trying to target. If I'm trying to target mainly fasting blood sugars in the morning, I'll tend to go towards the intermediate acting ones. If the blood sugars are high across the day, then I'll tend to go towards the long acting ones. There's really, when you look at the research between the two, there's really no difference in outcomes with gestational size or anything like that. There tends to be sometimes less hypoglycemia at times with the Lantus than there is with the NPH, but again, it's what I'm trying to target on these individuals. And again, also looking at lifestyle as well. Is it a lot to ask for 2 injections plus your Humalog versus just 1 ultra long acting? So we try again to kind of tailor to what's going on with them and their management. I had one lady the other day who's currently on NPH twice, and I want her to be on some Humalog, and she's not going with that because she has to work at lunch, and that's just not going to happen. And she doesn't inject herself. She has somebody inject for her. Right. So then it's just a matter of negotiating the best possible outcome. And when we talk about treatment, again, I always say that our targets are targets and their guidelines. And I always tell people that you're doing the best that you can. If you can't get that fasting to 5.3, that's okay. If we can get within that range, that's all right as well. Right. So just kind of letting them know that, acknowledging that they're doing the best that they can. And I find that the most resistance we get is when we really harp on, you must get down to this, realizing that it's a very tough disease to have. I say gestational diabetes is one of the best ones because it does go away after you deliver. So try to put a bit of a positive spin on it as well. So yeah, try to work with what they're going for. So.
Okay, thank you. I'll just pause for a second and remind participants to text in their questions if they have them, or participants in the audience as well to text them in. I don't see anyone jumping up yet here, so I'm just going to go with another question, Dr. Newstead-Angel, and then I'll move on. I've got a couple more for Dr. Sasakamoose, which are kind of related. And this one came by text for you. Who, how, and when do you transition a postpartum woman with diabetes in pregnancy to another healthcare provider?
So if they've had pre-existing type 1 and they're following with their family doctor and doing quite well, we give them their recommendations after, bring them back usually around 6 weeks again, trying to facilitate a combined appointment if they're seeing an obstetrician, and then back to their healthcare provider after that, if they're well. If they're struggling with glycemic control, I will bring them back every 3 months just to see how things are going. And I'll have them see myself sometimes. And we always talk about preconception care with their appointments. So it depends on what the relationship is. I'm used to more local group than ones that come from far away. But if they come from far away, we will make recommendations to their home providers on kind of what to do with their diabetes. If they're on insulin in pregnancy and they go back to their oral medications, and then they can go back to their care providers quite easily, again, just with their recommendations for goal targets and encouraging breastfeeding and kind of follow up long term as well.
Okay, thank you. Dr. Sasakamoose, how do we ensure, given what Dr. Newstead Angel has said about the transitioning, you talked about ensuring continuity, how important relationships are in ensuring continuity. How do we ensure the continuity of relationships and commitment that you've described, given the changes in personnel, people change, services change, health authority boundaries change? Do you have any suggestions as to how we can ensure that continuity of relationships so that we have healthy, positive, as you say, assets going forward?
Well, I think one of the larger gaps is it's difficult to have relationships when you don't have Indigenous people around. So if you don't have them working in your facilities, if you don't have them as doctors and nurses, you don't have student researchers and researchers, then it's really hard to have relationships. So people often say, well, how do I meet Indigenous people? And it's not really just about going to the Friendship Center and having tea, which is one way to learn for your own learning, but it's not going to help the healthcare industry. So we need to get more Indigenous people in the healthcare programs. We need to get more Indigenous teachers. We need to get more capacity built. The relationships themselves, I believe, if you're just talking about patient-client relationships, are just how you navigate that. And then extending that beyond. So, you know, maybe it's the whole family that comes in for care, because really when we put people back in their families, if you're the only one following a model of care and no one else is, you're likely to not continue. So it would be reaching out to the families and the kinships and the others that support the health and well-being of the client or the patient. And the other thing that I would suggest is that sometimes it's scary to say, get tested for diabetes, in particular HIV. I work a lot with HIV, so it has a lot of stigma involved. So what we try to do is, in community, we have liver health days. And so at liver health days, you get your liver checked, you get your diabetes checked, you get your HIV checked, you get, you know, and actually at the last liver health day at one First Nation, I went and got all mine checked. So it makes it easy and convenient, and then it's fun. The whole community comes, there's food, it's like an event, there's balloons, there's door prizes. And so everyone comes in, and it's more of a social fun thing with your community instead of, oh my God, I'm getting my HIV test today, and they know I'm walking in the door because I'm getting an HIV test. It's less threatening that way. So I think there's ways that you can do things that are fun and exciting and promote health and well-being without necessarily stigmatizing people, and that's one approach that we take.
Right. So then a shared approach that has a history of moving forward.
And for me, it was really good because I was in a community and all these tests were being done, and I hadn't gotten mine done in a while, and I thought, well, I'm just gonna do it.
Yeah. Okay.
So it makes it accessible.
Thank you. One last question for you, Dr. Sasakamoose. As First Nation individuals access healthcare in provincial clinics and tertiary centres, is there a partnership with the Provincial Health Authority in terms of awareness and utilization of cultural responsiveness and the strengths-based approach?
So with the amalgamation, we're seeing some approaches, we're seeing some areas that are working out. We have the Culture Responsive Framework now. The Federation of Sovereign Indigenous Nations is pushing this agenda. So I believe that we're in progress, and I believe there's some responsiveness happening, but there's still a lot of disconnection going on. And part of that disconnection is the lack of the unwillingness for the non-Indigenous sides to let it be led by Indigenous people. I think that's key. That when you say have Indigenous people lead it, that some kind of fear cord goes in, and you just see this resistance come up immediately. And that's where I believe my work is really trying to eliminating the fear that it's okay that Indigenous people take care of themselves and know how to take care of themselves. It really is okay. We don't have to have that parental sort of approach anymore. We are fully responsible adults that know how to take care of our well-being.
Having said that was the last question, I've had one come in by text message. For you, Dr. Sasakamoose, how can I decorate a standard four-walled office at a health centre to support Indigenous health and wellness?
It is a good question. I get asked this a lot because I did create a decolonized space. I would say gently that it's not just about putting art on the walls. So that's one approach, but it isn't just about that. But I would suggest asking your Indigenous patients, families, and clients what they would say would make your facility more welcoming for them instead of what you think would make it more welcoming for them.
Yeah. So that shared space.
Yeah.
Yeah. Thank you so much for your very fulsome answers to some really great questions. We're going to take a 15-minute break now, and our broadcast will resume at precisely 2:45. I would ask you to be back a couple of minutes early so we can start right on time. Thank you so much to Dr. Newstead Angel, Dr. Sasakamoose. Enjoy your break.